Good morning. This is Professor Yamamoto from Tokyo Women's Medical University. Thank you very much for your kind invitation to this important symposium. I'm very happy and to be honored to speak my topics. So today, I'd like to talk about resection of the HCC in cirrhotic patient. However, I want to talk severe cirrhotic patient, and then we reviewed our data in my institution. So you can see this is BCLC system updated 2016. So liver resection recommended is early stage HCC, single, without portal pressure is low and lower bilirubin level, resection is recommended. However, if the portal pressure is high, bilirubin level is high, it is recommended transplantation or ablation therapy. So also, this is a review article in Lancet Oncology in 2017. So American guideline and the European guideline recommend resection is not recommended in patient child PB. So ablation also not recommended. However, this is a Japanese guideline by Japanese Society of Hepatology and the Liver Cancer Study Group of Japan. It is a little different. Oh, I'm sorry. So you can see child A and B and no vascular invasion. So surgery is recommended as first-line treatment. And also, Hong Kong group proposed a new guideline in 2014. And in this guideline, so early tumor child B also recommended is liver resection. So the European, American guideline, Western guideline, and the Eastern guideline is a little different. So the Hong Kong group described this is a background is first different. So Hong Kong group and Japanese group guideline also recommended more aggressive surgery for early HCC patient, even if it is cirrhotic liver. So therefore, it should be validated in this guideline in non-Asian area and in the population with another etiology group. So therefore, we evaluated the short-term outcome, long-term outcome after hepatectomy for patients with HCC and compared child A and B patient in our institution. We retrospectively evaluated 2,482 patients with HCC who underwent hepatectomy between 1968 to 2014. So the child A LC patient is 849 and child B patient is 332. So I think this number of the child B patient of operation is one of the largest series in the world. So we evaluated the mobility, mortality, and long-term outcome after surgery every 5 years. So I'd like to talk a little about our procedure. This is Ken Takasaki, my boss. He invented the extrahepatic Grisonian approach for liver surgery. This is his procedure. So extrahepatically, Grisonian pedicle could be approached. So this is a anterior sectionectomy by Takasaki's method. This is a stamp of the anterior pedicle. And also, we could do the smaller resection, anatomical a smaller resection subsegmentectomy can be performed by this technique. I'll show you our data in these 50 years. So this is age before 1985. So green column is over 70-year-old patient is less than 10%. However, now our series that's over 70 years is 42, over 80 years 10%. Half of them are over 70-year-old. And another is a background. It's changed in this period. So 1990, so 60% of the patient HCB. However, HCB percentage is down and down. Now 38%, and non-B, non-C hepatitis is now increasing. This is HCC size and number and vascular invasion. So the indication of the surgery is changed in this period. The first, the multiple HCC is 40% in 1985. However, the percentage of the multiple HCC is down, and also single nodular 2 to 5 centimeter in diameter is growing under 39%. Vascular macroscopic vascular invasion is 10% in this period. In surgical procedure, our procedure, 80% of the procedure could be done by Takasaki's procedure. So from the 1985, 80% of the procedure were by Takasaki's method. So this gray column is a non-anatomical partial resection. It is about 20%. So this is a morbidity and the mortality in our series. So before 1985, the mortality rate over 10%. However, mortality rate is down and down. Is now 0.5%. And also, morbidity rate has been decreasing, and now is 13%. This is liver cirrhosis in our series. First, before the 1980, over 60% of the patients had liver cirrhosis. However, liver cirrhotic rate is down, and now our series is 41%. This is a child view classification. So around the 1990, child B is a red column, is 30%. However, the indication was changed, and now the 8% of the child B was performed operation. So it is due to we introduced the ablation therapy since 1996. First, we introduced microwave therapy, and since 2000, we introduced radiofrequency ablation therapy. So therefore, if the cirrhotic liver, severe cirrhotic liver, single nodule less than 3 centimeter in diameter, the ablation therapy was first treatment. So another point is ICG R15. So you can see the ICG 15 in child A and B. The median ICG in child A is 16%, and median ICG in child B is 30%. So it is significantly different between two groups. And the important one is the range is wide in each group. So therefore, in child B, so the range is less than 10 to 60%. So therefore, we should check the ICG level before surgery. This is a surgical procedure for patient with liver cirrhosis. In child BA patient, half of them underwent hemihepatectomy or sectionectomy. However, in child B, 40% of partial resection, and hepatectomy is 13 patients. So this is a morbidity and mortality in child A and child B. So you can see before 1985, mortality rate is over 10% in child A. Child B is also 50 and 40%. However, mortality is down in child A. However, the child B, its mortality rate is around 10% in 2005 to 9. So it is different in both two groups. And also this is a mortality and morbidity according to the surgical procedure. So the mortality rate is not so different among the procedure in child A. However, in child B, so mortality rate is much higher in hemihepatectomy and sectionectomy. So this is a multivariate analysis to predict 30-day and 90-day mortality. So the operation factor is not significantly important factor. However, liver function, ICG, liver cirrhosis, and operative factor, blood loss, operation time, and bleeding by leakage is important. And also, this is a prognostic factor for long-term survival on multivariate analysis. So ICG over 30% is important. And also the operation factor, blood loss, operation time, and blood transfusion, mobility is important. Also the tumor factor, multiple HCC and vascular invasion is an important factor to predict the long-term survival. So this is a whole survival curve in my institution. So after 1990, this red line is much better than before. So now our series 5-year survival rate is 78%. This black line is a whole Japanese data by liver cancer study group of Japan. So the 5-year survival is 57%. Our data is much improved after 1990. It is due to our procedure is completed. So this is a survival curve in patient with liver cirrhosis. So left side is a recurrence-free survival, and right side is a overall survival. Child A and B data was significantly different between two groups. However, we can obtain the 41 5-year survival in child B patient. I think it is acceptable data. So I'd like to talk a little about another aspect for child B patient treatment. So this is a radiofrequent therapy. In this article shows the 5-year survival rate up to the 38%. So if cirrhotic liver, small liver region, we should consider this ablation therapy for these severe cirrhotic patients. Another aspect is laparoscopic liver resection for patients with cirrhosis. Laparoscopic liver resection is feasible and safe in patients with child B when tumor locate in the anterior part of the liver. Compared with open liver surgery, the laparoscopic group display a significantly shorter hospital stay and lower mobility with less ascites. I think less ascites is very important message, and disease-free survival and overall survival was similar between laparoscopic hepatectomy and open hepatectomy. So this is my conclusion. So hepatic resection is feasible in selected HCC patient with child B LC, liver cirrhosis. The evaluation of resectability and the pre-selection of suitable candidates for surgery are important, but sometimes difficult. ICG R15, tumor size, number, major vascular invasion, location, and patient condition are considered for the choice of treatment. Thank you very much for your attention.